So I'm going to invite, to join Dr. Kaplan on the panel, I'm going to invite also from the University of Pennsylvania, Dr. Mona Al-Muqaddam, and then also from the Mayo Clinic, Dr. Bob Pignolo, and then from the University of California at San Francisco, Dr. Ed Shao. And so how this session is going to work is, first of all, there are colored note cards on your table. So if you have a question, maybe already in your mind that you want us to ask, if you want to just jot that down and then hold up the card, we'll stop and grab that for you. But we are going to start by having Dr. Pignolo, Dr. Shao, and Dr. Muqaddam also talk about some things that we see you asking questions about and discussing on the online support groups all the time. So those topics are going to be, one of the topics that Dr. Pignolo is going to cover is going to be kidney stones. There's a paper on FOP and kidney stones, so he's going to talk a little bit about that. We're also going to have, Mona is going to talk about puberty, and then Ed Shao is going to talk about lung health and spirometers. So I am going to start, let Bob start, and then after those three presentations, we are going to open it up for questions.
Thank you, Michelle. Good morning, everyone. So I'm tasked with telling you about kidney stones and FOP. Let me start with a true story. Yesterday, I went to the men's room, and I saw an individual with living with FOP. I said hi to him. He said hi to me. He did his business and left. I did my business and left. When I walked out of the men's room, we shook hands, and he told me he just passed a kidney stone. And I knew this person living with FOP, and I knew he had a history of kidney stones. And I certainly could appreciate the pain that he must have just been going through in passing a kidney stone, because I myself suffer from kidney stones. I've passed more than one or two myself. But the point is this, it's very, very common. How do we know that? We know that because in 2018, we published a paper looking at two different data sets which looked at the prevalence of kidney stones in FOP. The first data set was collected in 2004, and that involved a survey looking at all of the current IFOP membership. The survey had a 54% response rate, and the prevalence of kidney stones by that data set was about 9.2%. And then in 2016, as a result of the Clementia Natural History Study, we were able to take a look at 114 patients. And out of that group, about 8% reported a history of kidney stones. We know from both the 2004 and the 2016 data sets that those individuals that had a history of kidney stones were also much more likely to have urinary tract infections. In both data sets, men were more likely to suffer kidney stones than women. In the 2004 survey, a big risk factor seemed to be immobility. In the 2016 Clementia Natural History Study, we didn't ask the question about immobility, but we did have CAGES scores. And for those of you who don't know what CAGES scores are, basically it's a quick assessment of joint function, and the higher the score, the greater the immobility. So we had an indirect measure, and in that data set as well, those that had increased immobility had a greater likelihood for kidney stones, suggesting that with immobility, there's usually an unloading of the skeleton and increased bone turnover, and perhaps that was related to increased release of calcium into the blood. So we have very strong evidence that about the prevalence of kidney stones in FOP. And if you compare the prevalence in FOP with the general population, it's about a threefold increase in the FOP population, so not insignificant. Just for fun, I went through the list of patients we're going to see this beginning today at the Ask a Doctor sessions. And just from my own knowledge of patients, 3 in the group I know have history of kidney stones, and given how many patients we're seeing, that it actually was about 8% just from this very small sampling. So I think the numbers are real, and kidney stones and FOP are common. So how does one present with a kidney stone? Well, usually it's an acute onset of flank pain, either on the left side or the right side, with radiation into the groin. Once you've had a kidney stone, you'll never confuse it with a flare-up, I think. And my wife and I used to have an argument whether or not the pain associated with kidney stones was more than the pain of delivering a child. And it was an ongoing argument for many years until I had a secretary who was pregnant who had a kidney stone during her pregnancy. And after she delivered and came back to work, I asked her the question, and she said, without hesitation, passing the kidney stone. I still haven't won the argument, but I'm just saying that this is a good example of how bad the pain can be. If you haven't passed a kidney stone, one indication might be in a urinalysis having the presence of red blood cells and/or crystals. So and I can tell you generically, when we do the urinalyses in many of the clinical trials that we're doing now, that these are very, very common abnormalities in the urine, especially in those with history of kidney stones, but occasionally in those who have not yet had their first kidney stone. So I want to conclude by talking about the do's and don'ts of kidney stone prevention. Do drink lots and lots of water. There are many good studies, including very large studies, showing that just drinking between 1.5 and 2 liters of water a day is sufficient to essentially reduce the incidence of kidney stones almost to nothing. So do drink lots and lots of water. Or I should say, don't eat a lot of protein in your diet or excessive amounts of protein. Do not have a lot of, do not incorporate a lot of salt in your diet. If you've already suffered from a kidney stone, do try to find out what the composition of the kidney stone is, because then there are possible dietary manipulations that can help you. If you don't know what the composition is, the most common type of kidney stone is called, or composed of calcium oxalate. And so you can look up what the sources of oxalate might be if that is the type of stone you have, and you can reduce the amount of oxalate. Do not decrease the amount of calcium in your diet. It may sound counterintuitive, but there's very good data which suggests that if you decrease the amount of calcium in your diet, you actually increase the likelihood of kidney stones. So just to quickly reiterate, lots of water, no excessive salt, no excessive protein, so no Atkins type diet. And if you do know the composition of your kidney stone, appropriate dietary modifications based on what the composition is. Thanks.
Hi. So for the people in this room who don't know me, please call me by my first name. So it is Mona. Don't worry about al-Muqaddam. Half of the people cannot pronounce that, so it's fine. I am an adult endocrinologist at the University of Pennsylvania, and I was tasked to talk about puberty and FOP. So that's not a very easy topic, but talking about puberty in general, it is a time when a lot of changes happen. When we say a child goes from a sexually immature person to a sexually mature person. And there's a lot of changes that happen. and there's a lot of variability from one person to the next. My mom went through puberty around the age of 9. I went through puberty at around the age of 10. And what did that mean? It meant I was the tallest girl in class, and I had my period earlier than my friends. But that didn't bother me. What bothered me was my brother, who's 1 year older than me, didn't go through puberty until 5 to 6 years later. And he was literally half my size. And whenever we would be introduced to people who didn't know us, they would always ask, who's older? And it was always going to be, my brother is 1 year older. And the response would be, wow, you look like you're his mother. And my brother's response was, I was born to be a schmuck. Now, if you see my brother, he's really tall, and you could think he's an NBA player. But truly, what happens during puberty is there's a lot of hormonal changes that happen. And those hormonal changes change your physical appearance and are responsible for the development of a lot of our organs. We routinely think of the ovaries and the testicles, but it's also responsible for our skeletal growth, for our height, so we actually gain height, and we gain a lot of bone density, and that's when our bones become stronger. And our growth plates close, and we stop gaining height. And so all of these changes come not only with physical changes, but a lot of emotional changes, and it is hard. And for our females, for us girls who start getting their periods, that's also a tough change that we have to adjust with. So that's puberty in general, and I have some teachers in the room here, and they're telling me, oh, puberty. We can tell you about puberty in our children. But what do we know about puberty and FOP? Really not that much. So we don't know that much that's been well studied or that's been well documented. What we do know is just from going around the room, talking to patients, talking to families, talking to colleagues of mine and asking them, what do they think? Well, some people seem to go through puberty and they're fine, and they don't have increased activity or increased flare-ups. But then we do know of several families or several patients that said, oh, the day that I started going through puberty, that's when my disease flared up completely and my life has changed really tremendously with puberty. Now, we can think of it as maybe it's all of these hormonal changes that are activating maybe activin A or some other hormonal changes that are contributing to this increased flare-up activity, but we don't really know because some people seem to go through puberty and not have any problems. We could think it's maybe because of the increased size of the bone and then also the muscle being pulled at. Maybe that's causing some trauma to the muscle, causing increased flare-up activity. We don't really know. But it is something that we should probably look into and better understand. What are those hormonal changes that could contribute to increased flare-up activity? And also in the future, how medications that we're going to try using in younger FOP patients, how could that affect kind of pubertal growth and kind of some of the hormonal changes that can happen with puberty? What we do know is that those hormonal changes that happen with puberty are important for normal development. And we would not recommend that you try to prevent this puberty from happening because we do know that it's important for normal organ development. What we do know is in a lot of our FOP females, when they start getting their periods regularly, it becomes extremely difficult for them for self-care. There are forms of contraception that can be used to decrease the frequency of menstrual cycles and sometimes also prevent menstrual cycles from happening. That requires a very long and extensive discussion with your doctor before going that route. What we do recommend is to try to avoid devices. We've looked into it quite a bit, but if you're thinking about an intrauterine device, there might be some difficulty in trying to remove that if there's any complications. Sometimes you're positioned in a certain way that might allow you to undergo a certain procedure, but maybe 2 to 3 years down the line, your physical the function is different, and maybe you are unable to undergo similar procedures 3 or 5 years down the line. There are certain implantable devices that we do not recommend. They can go into the muscle and can also affect a lot of hormonal changes in a negative way. So Again, also with any medication, there are side effects, and so thinking about oral contraceptives and increased risk of blood clot is something that we do think about. So definitely have a long discussion with your doctor about the pros and the cons of different forms of contraception. Thank you. I'm sure I'll have a lot of questions, and I'm not sure I'm going to be able to answer a lot of them, but I think it's an important topic that we should definitely look further into and kind of research that some more. Thank you.
All right, thank you very much, Michelle, and also to our sponsors from Ipsen and Regeneron. So I'm Ed Shao. I'm an endocrinologist like Mona, and I'm over at the University of California at San Francisco. So we have a center there, and we're happy to help take care of patients with FOP and other rare diseases. So what I wanted to talk to you about today is actually something a little bit different. We talked about this, I think, last year, but every year I think it's an important topic, and it's actually respiratory health. And I get to be sort of the demo person, so I'm actually not sure if the video will work to be able to show on there. But there are a couple of things about respiratory health, and I think, as Michelle had mentioned at the beginning, incentive spirometers will be available to the people with FOP, and so those are these items, and I'll demonstrate to you how they work, and I will apologize in advance to the parents because you may hate me after this. But one thing about the respiratory health is that this is an important and very critical part for any patient with FOP, and especially patients who have chest wall involvement. One of the things that we like to do is try to optimize respiratory health over the long run. And so the exercises that I'm going to tell you about today are not just a one-time thing. These are things that we want patients with FOP to do on a daily basis. And the idea behind it is really maintaining respiratory capacity, because in the long run, your respiratory capacity is critical for being able to cough and clear secretions, able to clear infections, and then, in the future, if there are ever any types of procedures or any things that needs to happen where you need to have to go for surgery or things like that, even though we try to avoid that, there are certain situations where we have to do that. Your respiratory capacity is a big determinant of how well the procedures will go. So the main thing to think about is that what we would like is approximately 15 to 20 minutes of active respiration exercises every day. For those of you who like to sing or have children who like to sing, I would strongly encourage that, and the easiest way to do that is to get them to sing for 15 to 20 minutes. If they're in a choir, that's awesome. If they're outside of a choir, if they're in the shower, put them in the car, someplace, so that it doesn't bother the rest of the family as much is fine. But the idea behind this is really to allow them to really vocalize and to really use their respiratory muscles as much as possible. And we're not talking about 15 minutes cumulative over the day. We're talking about a dedicated 15 minutes a day where they're actually doing respiratory types of activities. We recognize that not all FOP patients can actually do those activities, and that's where these devices come in. So I'll show you the first one, which is actually for kids. This is called a peak flow whistle. This is actually used for patients with asthma, and we're using it for a totally different purpose in this case. So the peak flow whistles work great for kids, typically kids under the age of 6 or so. And the idea behind it is that you blow through it and you get a whistle. So there's an incentive to it to make noise. And this, again, is why I will apologize to the parents in advance. But the idea behind this is, so you can, when you get the whistles, I think it's over in the tools box over there, but in the room over there, I don't know, or at the front desk, Michelle can correct me where, or tell us where they are. But the idea behind this is a little bit different. So again, this is blowing out. But the important part for respiration is actually taking the deep breath and expanding it as much as possible. So what we generally recommend for this is that it doesn't really matter what the setting is on the whistle. I would actually set it to the lowest point because we're not trying to encourage people to blow out fast. What you want to do is to have the child take a deep breath and then exhale through this. And then you'll get a whistle, and then that's actually a nice way for them to encourage. So the idea is take a deep breath, hold it for about 10 seconds, and then blow through. So I'll just demonstrate that for you. I'm not going to blow into here. So. Okay, so you'll get the whistle from there. That's all you're doing. And what we usually do for the peak flow whistles is usually about 10 times of that cycle of taking a deep breath, holding it for about 10 seconds, and then blowing through. Okay? Again, the important part is the deep breath at the beginning, not the whistle. For the adults and for the older kids, we have these, which are called incentive spirometers. These you can sometimes see in the hospital. If anybody has been hospitalized, they often hand these out, and you may be sent home with one of them. But these are a little bit different. And the idea behind this is that there's a little flow meter here that tells you how fast to flow. And these actually work on inspiration. So you blow out first, and then you inhale. And I like these better because what this does is you're trying to inhale slowly over a period of time, not over a longer, not very rapidly. And so there's a flow meter on one side, which you'll see, and this flow meter allows you to see how far you're going. And so there's the little markings that say good, better, best. That's sort of where you want to keep this little float in. And then there will be a little white float on this side that tells you the volume. The exact numbers that you see on this or on the peak flow don't matter. Okay, that's not what we're shooting for. We're not shooting for, how much volume can you blow, how much hot air do you have. That's not the idea. The idea behind this is really just to get the cycle through and really to take the deep breaths and to really inflate the lungs. And this one, when you inhale through this peak flow, through this incentive spirometer, the idea behind this is to expand your lungs, expand your lung tissue as much as possible. Okay, so for this, you exhale first, and then you slowly inhale, and you try to get the little float up as much as possible. But you don't want to exceed the speed on this one. So okay, so that you'll see that the float goes up, and then there's a little thing here that you can move up and down to see where you were before. If you're sort of self-competitive and interested in writing down what you like to do, then you can do that. But again, the exact number does not matter. So each person is going to have a slightly different number. That's okay. If you really want to set it with medically, bring this to your doctor, and they can use your pulmonary function testing that you have through your clinic, and that can be a way of setting things. But really, these are the two tools that I think are really important for trying to move forward, maintain your respiratory health. It does bring up one thing, is that we do recommend that patients with FOP have at least one pulmonary function test done at some point, especially when there's chest wall involvement. As kids, usually not as critical until they start having chest wall changes or some of the scoliosis or the kyphosis. But really, that can be a very helpful measure of understanding the progression of the disease and watching the respiratory health. But again, these are things that we would encourage patients with FOP to do every single day. Try to work it into your routine if you can, because I think that would be really great. The other thing, just really quickly, that I just wanted to bring up related to respiratory health is the flu shot. So the flu shots, you should discuss with your physician every year. We do recommend that you do have the flu shot, but not to have the flu shot given intramuscularly. So the formulations that are available this year are primarily all intramuscular. In some years, there's a transdermal that can be given, and then there's also a subcutaneous form that can be given. Intradermal form that can be given. Those have not been approved yet as of this year. But one of the things that is really important to consider is getting the flu shot. If the FOP patient does not feel comfortable getting the flu shot, definitely the family should get a flu shot just for herd immunity. But if you do get the flu shot, what we usually request is that they take the intramuscular form and do it subcutaneously. Information is available on the IFOPA website, in our treatment guidelines, and also on the ICC website with the specifics. You can share that with your pediatrician or with your doctor. The other thing to remember is that part of the important aspect for pulmonary health is just avoiding infection in the first place. So the flu shot is helpful, but it's not perfect. And what we do recommend on those is that in some situations, particularly if you're traveling through crowded areas, is to have like a surgical mask. There are some people who will want to use things like an N95 mask, which is the really high filtration mask that can filter out TB. those are extremely uncomfortable when they're used properly. And the majority of people don't use them properly. They have to be fitted, they have to be sealed. So what we usually recommend is just considering a regular surgical mask. The idea behind that is to stop the big droplets like somebody accidentally sneezing on you. You know, that's the type of thing to avoid. It won't stop viruses, it will not stop bacteria, but it's really just as a preventive. And then also hand washing is really important. So I believe they were handing out little bottles of the alcohol. That's really important to use. It's really important to try to keep your hands and the people around you as clean as possible. So really a lot of that is prevention, and a lot of this is really trying to build up respiratory health. So I'll be around afterwards, happy to demonstrate with these guys, or if you have any questions, after you pick up yours, I will be around, and hopefully I will hear lots of whistles as we go around today. Okay, thank you.
Okay, thank you. So now we are going to start the Q&A time. So this is your opportunity to ask questions. Marie has a mic. Sammy, who runs the FOP registry, is in the back of the room with the mic. We've got the cards on the table. If you don't want to stand up and ask your question, we can take it by the card. Just put your card up and we'll come get it. Or you're welcome to ask a question. So I think we're going to start with Fidel.
Thank you. Hello, I am Fadel from Saudi Arabia. My daughter Noura is 21 years old and she's a FOP patient. You know, the first time, she has been seen several times by Dr. Kaplan and one with Dr. Muna Al-Maqdam. I was trying really to bring her here, but I'm sure she feels sorry for that because I sent her a picture of last night with the wonderful community that she can really integrate and understand better than carrying the information to her. So hopefully next year that she attends. But I go back to Dr. Kaplan, please. Through the lecture that I heard, the FOP, I would say the basic step of discovering the FOP issue was in the beginning 90s. And there are too many efforts and endeavors being taken to combat this medical difficulties. Doctor, please, if you can, let me know in a simple manner, and that's a question of Noura actually. How is the climb rate of really toward this FOP? Is it a steady climb rate, or there are some zoom up due to the jointness of other participants, like the pharmaceutical companies, the community themselves, the researchers, dedicated doctors for specific fields? So to reach that hope that you brought in and to bring it in earlier years to find the medicine.
Sorry.
Thank you so much.
Thank you, Fadel. Because of the echoes, I couldn't hear it very well. Oh, I'm sorry.
How you see the involvement of all concerned parties, pharmaceutical companies, families, researchers,
I see.
any other medical institution, to bring that hope earlier to
Right.
cure the problem?
Right. Well, you know, I think we have to go back a little bit and sort of take a historical perspective. Back in 1988, when I first got involved, there were just a handful of patients known throughout the world with FOP. There was no cell phones, no social media, nothing. And so we embarked upon this really to the criticism of many of our colleagues around the world. They said, what are you doing? I mean, why are you spending your time on such a rare disease? You should work on more common diseases. And so it took a long time to convince doctors and scientists that FOP was worthwhile. We started having symposia in 1991, and then in 1995, in 2000, and 2007. And we brought doctors and scientists together who were very knowledgeable. And wanted to learn about FOP. We clearly wanted them to learn about FOP, and we brought patients there because, you know, you can't learn about FOP from a book or a slide. You can learn about FOP from being here and talking to families and seeing what they're going through every day and seeing what the struggle is with FOP, living with FOP every day. It took a long time, and I think the editorial that Science wrote after the gene discovery was really about that. It was about building a community. Then in 2006, we had the discovery of the FOP gene, which gave, along that time, there were tremendous advancements in science that made inquiry of diseases more possible. And then with the discovery, all the tools were in place, and it took the pharmaceutical companies, and they started working on this almost immediately. It's not an easy problem to solve, and it's not an easy problem to develop medicines that are specific and potentially efficacious and potentially safe to try. We didn't have an animal model. We had no way of knowing what is going on. So basically what I'm saying is it takes building a community. And this is not done by one scientist. There's no one scientist that's going to find a cure to FOP. This is building a community. And it's events like this, and I think, you know, I would encourage those of you who are new to speak to some of the older folks in the community. We now have tremendous hope. I don't know if any of these drugs will be successful. None of us know if they will. That's why we're doing clinical trials. But the more we build communities in different parts of the world, the more clinical trials there will be. There are almost more drugs now than FOP patients, potential drugs than FOP patients. I'm exaggerating. But we hope that each one will have each one that's a potential and brought to clinical trials, we hope that those clinical trials will fill. It's really important to build the communities, not just internationally, but in each area, in each country, having a doctor, having a family that's interested, having a center of excellence for the care of FOP patients for their everyday needs, and then being able to run a clinical trial responsibly. It's going to bring answers quicker to the FOP patients.
Great, thank you.
I just want to add one more comment. So I joined the FOP community about 3 years ago, and the first time I attended the drug development forum, I felt this is how medicine should be practiced in every field. It's rare to have a conference where you're having scientists, researchers, drug companies, patients, families, all discussing the same thing and learning from one another. And similar to what I tell my daughter, what works? Teamwork. And really kind of the teamwork is what is very important. And now moving into all of these clinical trials is really kind of data sharing and kind of working together to speed up the process. And I think that's basically what all the families are asking for, and kind of the time is ticking. And yes, there's so much hope, and it's absolutely phenomenal to see what Fred Kaplan and everyone else has been able to accomplish in the past 30 years, because usually you don't see it in one person's lifetime where you understand the disease, you identify a gene, and now you're actually potentially in drug discovery. And so I do think that the reason why it's been so successful is because of that teamwork. And in order for it to continue to be very successful is kind of that collaboration and data sharing is going to be very important.
Right. And also, people sitting in this room last night after dinner, I was talking to one of the families. It was a multi-generational family where a parent had FOP, passed it on to a child and so forth. And I said to the family, it was here right now, do you understand how important you are to where we are today? And that's true with all of you. Some of you have given blood, some have given urine, some unfortunately had a biopsy, which we retrieved and looked at and studied and are able to understand the molecules and the cells that are going on, to be able to, the animal models give us clues, and then we have to confirm them in the patients or vice versa. And so these are very important. All of you can participate in the FOP registry, which will help all the families, all the patients can participate in the FOP registry from wherever you are in the world. And that's one way to contribute to research, to accelerate this pace. We had a drug development forum 2 years ago, and I don't know if any of you were there in the last several days, but it truly was exhilarating to see what's going on in the world. And I can assure you that the pharmaceutical companies and the patients, the doctors and the scientists all understand the urgency of bringing these clinical trials. It's through the clinical trials that we'll be able to see if the drug works and if the drug is safe enough to be able to use. And I'm hoping that when we meet probably 2 years from now in a drug development forum where we have many more clinical trials and we have results from the clinical trials that are going on now. And we're going to hear later this morning from the pharmaceutical companies where they are. So I think there is great hope. I wish, I go to bed every night, and I'm sure every other clinician here goes to bed every night thinking, I wish I could just tell the patient to take this pill and it'll all go away. It's like walking through quicksand for us. But the pace is accelerating, and it's accelerating rapidly. So,
And I want to add one thing, because I completely agree with that. I think the sense of community is absolutely critical. And it's not only because, being able to support research and these types of connections, but this is how we, as sort of the healthcare portion of this, learns. This is what what you give into us in terms of feedback through the registry, through the clinical trials, through even the Ask a Doctor or Ask a Dentist, those help us identify what are the critical needs. Those help us identify what sort of health issues you, as families, as caregivers, as patients are dealing with so that we can help try to address those. And the more participation and the more input that we get, it's hugely valuable in terms of helping to direct the next steps.
right, and it also absolutely essential for the clinicians, as Ed said, and also for the basic scientists who are able to talk to the families and be able to understand these problems and decipher them and dissect them and take them back to the research laboratory and said, at the conference I heard this was a problem. When we heard Mona speak about puberty, for example, is it the hormones that are causing some children to reach puberty and hit a wall where the flare-ups become more active? Or is it the growth that occurs with puberty? The bones grow, we all know that, but the muscles have to grow with the bones. So those fat cells, for instance, are they becoming more active? Are they expressing different markers? Those are the comments that will be taken back to the laboratory. And now we have the models, now we have the opportunity to answer that. So first of all, I am absolutely delighted that you're here, that you've traveled probably the furthest of any family in the world to be here and to take this message of hope and acceleration back. And I'm hoping that we're able to establish clinical centers in places in the world where we don't have clinical centers, so we can bring clinical trials to those communities. So thank you.
Great. So we do have a question that was submitted. I wanted to ask, is there a high incidence of gallstones or gallbladder issues with FOP?
Oh, in the last 30 years, I've seen a few patients with gallbladder problems, but we haven't conducted any studies, and it hasn't been raised to a level of awareness where that is a particular problem. Have you guys? Have you seen
I only have one patient who's had a cholecystectomy, so the removal of the gallbladder, but I don't know of any.
So we recently wrote a manuscript looking system by system using data from the IFOPA registry. Gallstones were not among the GI complaints that were listed by participants. So I think at this time it's not.
Yes, this is for Dr. Pignola. My son has had a history of kidney stones that he's been able to pass, but he also has a big one that's too big. We're followed by urologists, and I wanted to know what was your recommendations if he should have get necrosis and that stone move.
Sure, that's a great question. I can only answer anecdotally, and I think Fred can probably chime in here too. It appears that urological procedures tend to be less harmful than other procedures in terms of the likelihood of flare-ups. I'm not aware of anyone who has had the type of urologic procedure that seems like would be required in your case. However, I think the risk would be lower than in other types of procedures, other surgeries.
Yeah, I think one of the things we're most concerned about is certainly patients with FOP get what everybody else gets. They get appendicitis, they get gallbladder problems. We don't know that they're any more common or less common than in the general population. Kidney stones clearly more common, as you said. But I think the main risk factor is not the surgery to take care of the emergent problem, but the anesthesia that's necessary to do that surgery. And I know that Dr. Grunwald is going to address that issue later this afternoon or tomorrow.
How effective, excuse me, is getting the flu shot subcutaneously? Is it more or less effective than getting it intradermally? Our son is 7, and our doctor has not been real forthcoming or real certain about what he should do. So I was just curious if you could comment on that.
Sure, I think that's a great question. So traditionally, actually, you can give a smaller amount of the flu vaccine intradermally. And because the intradermal route actually has a better immunogenic response as compared to subcutaneous. What we found is that many clinical sites have difficulty giving it intradermally correctly. So if they are able to give it intradermally, that would be fine. It actually has a smaller volume. We can provide that information. What we generally recommend is that you take the intramuscular dose, and depending on the size of the intramuscular dose for that particular formulation of the vaccine, is to give it subcutaneously either in one location or in 2 locations. And that seems to work pretty well. And in the case of these vaccines, we usually give them with Tylenol, or ibuprofen to try to suppress any sort of discomfort related to the site. And we generally recommend, because we're already off of the standard protocol, we generally recommend, if it's a site that's already been ankylosed so that they don't have movement, just in case that there is a very low chance of a flare, but if there is a flare, that you don't actually take out a new joint or something along those lines. For the most part, there is pretty much no data that says if you take an intramuscular vaccine and you give it subcutaneously that it's going to work as effectively, so there is the chance that it won't work as well. But at least for past flu vaccines, the fact that we know that they can give similar formulations through intradermal or subcutaneous suggests that it should be fine. And we think that any increase in a person's ability to fight off some of these major infections is better than no increase in those situations.
But if they're having a flare, we
Oh, right. Yeah, and actually that's a critical thing. Thank you, Fred. I'd written that down to add here. One of the important things is that if somebody has had a flare within the past 4 weeks or so, we do not recommend a vaccine, any type of vaccine, just because there is a risk of re-triggering the flare. So typically wait until the flare is over, that starts the clock, wait 4 weeks, and then do the vaccine. It does mean that you may miss the vaccine for that particular season, but that's okay.
Okay. I think there's a question on this side.
Hi, good morning. This is Barbara Carmichael, and I'm asking the question for Jonathan. He would like to know, will the new medicines be covered by insurance? And if not, do you have any idea how much it might cost per month? Thank you.
That's a really good question. I don't think that any of us are able to answer that. They'll probably be very expensive, some of the newer medications, and we're going to punt that question, I think, to the pharmaceutical companies who are going to speak to you soon. So it's a very good question, Barbara. I don't know that. In certain areas of the world, the insurance companies are the countries, because there is socialized medicine. It's available to everybody, and the ministers of health of those countries will decide, even if the medication is shown to be scientifically efficacious and relatively safe, the scientific ministers, health ministers of those countries will decide whether those medicines are going to be available. And so, but in the United States, I don't know, and what the relative cost will be, I don't know, but it will. Those medications will be expensive. Yes. Yes.
Yep.
Hi, my name's Tiffany. My son Daniel is 13. He has FOP. And first I want to express my profound gratitude for everybody here and this whole weekend. It's just, I'm in awe of the ideas and the community. But my question is, you know, Dr. Kaplan, you had the little devil icon up there about inflammation and hypoxia. And my question is more related to diet. And I have some thoughts that diet is really profoundly related to tipping the balance towards inflammation, especially in my son's case. And I know, Dr. Shao, you had the microbiome study going on, looking at, you know, things, in our case, things like sugar and food dyes and gluten, dairy, that upset the gut, a lot of GI issues that I think contribute to this inflammation in the body. I wonder if there's any further research or any other findings along diet recommendations for our families, for our kids.
It's almost inconceivable that what we take into our bodies doesn't have some effect on the function of our bodies. But what that actually is, we don't know. And I know Ed is working on that right now to try to sort that out. There are so many factors in terms of, like, does the diet, not just the metabolites of those diet, but how does the microbiome affect those metabolites, and what does it do? And it might not be the foods that we take in, but metabolites made by different bacteria that affect the inflammatory cascade. So, you know,
Yeah,
you may want to address that.
I think that's very much true. I think there are a number of nutritional things in FOP that we have to balance. So one is the potential, you know, there's discussion about pro-inflammatory diets and anti-inflammatory diets. But all of those you have to balance with issues related to total nutritional, sort of the total nutritional picture. I think the biggest challenges are in patients who have had ankylosis of their jaw, so they're not able to chew, or they're not able to, you know, they're more limited to a liquid diet. And what we generally do is we try to work with a nutritionist so that we make sure that they are able to get the main macronutrients all together, and that they have sufficient caloric intake, you know, to support that, their activities. Because one thing that is very clear is that if you do not have a good nutritional base, patients, not just FOP, but just in general, patients do much worse. You know, that's actually a very important part of health. So we try to take all of that into account. My general philosophy to any of my patients, not just FOP, is that things in moderation is good. You do not want, you know, the pro-inflammatory diet with high-fat fried foods, things like that. You don't want a lot of that. You also don't want to be completely, you know, for patients who choose to be vegan, you know, we have to be very careful in making sure that they get sufficient protein sources, other types of things. And so it's a balance. I think at least as of right now, there's no specific recommendations except to try to keep the diet as varied as much as possible, and certainly making sure the nutritional content is sufficient.
I can add to that we equally don't know enough about micronutrients in FOP, with the possible exception of calcium and vitamin D. And the only reason why we have a better handle on that is because we often give bisphosphonates to patients with flare-ups, and we always check those micronutrients prior to giving those drugs. And at least in the case of vitamin D, my experience is that most patients with FOP are vitamin D deficient. And so I think, and the only reason why I'm mentioning this, I think there is probably good reason to start looking at at least some of the micronutrients that we can measure, just to get a sense for, are there others that we can identify where, for one reason or another, patients living with FOP are particularly deficient in.
Good morning. My name is Dagmara. So this is a good follow-up question because it also relates to diet. So when I experienced jaw fixation, I dropped a lot of weight real quick. So I went to see a dietitian, and she's no FOP expert. She was just a dietitian in my area. She said to minimize my calcium intake because it might cause calcification. She wasn't sure. And then she also said to keep eating proteins because I need like the nutrition and then caloric stuff. So because it's hard to eat like certain like meats and stuff, so I've been taking protein powders. But like now, this is more geared towards Dr. Pignola because he touched up on it, and it's complete opposite. So you said it's okay to eat the calcium and to minimize the protein. So I'm just seeing like how much protein is okay, or like more information on that.
Let's put kidney stones aside just for a moment. Even the recommendation to reduce calcium in your diet, I would disagree with. Everybody should, for their age, should have normal calcium intake through their diet. So I disagree with that. And again, kidney stones aside. In terms of the protein, and again, kidney stones aside, I think in the setting of the dramatic weight loss that can occur after jaw ankylosis, you do need adequate amounts of protein. So in that setting, I think you need to get for your age and for your size, you need to get adequate protein. What I said in terms of kidney stones was that you don't want a diet with excessive protein.
So we usually recommend starting with the US RDA guidelines and using that as a starting point. And then the modifications that usually occur off of that are going to be based on, is there decreased mobility, is there decreased jaw movement, things like that. But usually those guidelines, which will give you rough ideas for, macronutrients and micronutrients, are a good starting point. I would also agree, don't cut out calcium, because I think there's some people in the community who will say that, okay, well, you have too much bone, therefore you shouldn't take more calcium or vitamin D. That's not correct, because in patients with FOP, what we see is that the native skeleton does tend to develop osteoporosis. And so it's important to make sure that all of that is supported as much as possible, that you don't sacrifice that, and that you take adequate nutrients in. And that's something that I'm happy to discuss offline and help you with those types of ideas.
Yeah, I just wanted to comment. I mean, exactly kind of to echo what Bob and Ed were talking about. Calcium intake, we never tell our patients, even if they have high serum calcium, to eliminate calcium from their diet. And usually, you can get calcium from your diet by, drinking milk, yogurt, cheese. If you have some lactose intolerance, a lot of patients like almond milk, so some almond milk has some calcium fortified with that. The vitamin D issue is also something that we do see a lot, where people can have vitamin D deficiency, and that's probably something that you're not going to be able to get as much from your diet. So fatty fish has some vitamin D, but most of the time, actually, the vitamin D would be through supplementation, and we don't think that vitamin D supplementation, if it's done in the adequate amount, not excessive amounts, would increase risk of kidney stones. So I think those things are important, but the take-home message is really everything in moderation. And we, even in people who have kidney stones, we never say, we have to be on a very low protein diet. It's just avoid excessive amounts of protein. And I think that's going to be, and so that might be in line with what the nutritionist was already recommending in terms of the protein intake. But I do have to say that the calcium recommendations are sometimes incorrect, and that's not only from your nutritionist. We see it quite a bit. It's very common, actually, where people have a misconception about how much calcium they should be getting.
Yeah, I was just going to say that the other issue about vitamin D is severe vitamin D deficiency can in itself cause inflammation. And we know this from children with rickets who have vitamin D deficient rickets, less common these days, but still there's tremendous amounts of inflammation of many tissues. And the vitamin D basic scientists have shown us that severe vitamin D deficiency can cause inflammation, and we don't know what that means. So again, putting this into perspective, our bodies generally work in balance. Too little or too much of something is going to be harmful. It's just the right amount. So we're not saying that you should overboard on calcium or vitamin D, but you definitely should not undershoot either.
So another card has the question, I see families talk about drugs they're using on social media, not just prednisone or Celebrex, but imatinib or pamidronate. How and why are those drugs used?
Yeah. I'll take pamidronate first. One of the things that's known, not from the FOP community, but from general use of steroids, is that they deplete the body of bone, and severe osteoporosis can develop from a repeated lifelong use of steroids. And I think the endocrinologist Ed and Mona can testify to that. So we often use those drugs, when we use prednisone to manage the misery of a flare-up, not whether a bone is going to form or not, because we don't know, but the misery of a flare-up. Cumulative lifelong doses of that can lead to osteoporosis, and that's prevented by the bisphosphonates if it's given prophylactically. So again, the judicious use of that can be helpful. There have been some reports, but they're anecdotal reports, that they may help flare-ups, and sometimes we will use that to see if we can quell a particular flare-up, but we really use that to abrogate the effects, to lessen the effects of the osteoporosis that occurs in the skeleton.
So just to mention, the bisphosphonates are basically the pamidronate, and sometimes we use also zoledronic acid, and both those medications are given intravenously. Pamidronate has been studied in younger patients more, in a different disease where they can fracture more, like osteogenesis imperfecta, and I think that has been used quite a bit in FOP patients, and sometimes we also use IV zoledronic acid. But both of those medications are bisphosphonates, and like Fred mentioned, we usually use them to protect the normal bone from the negative effects of prednisone, and maybe hoping that it could help with the flare-ups, but we don't really have data to support that. And I think the next medication was the imatinib that they asked about.
Yeah.
Actually, before you move on the bisphosphonates, so it's really critical that you have a good discussion with your local doctor or an endocrinologist about this, because although we use the bisphosphonates for the steroid-induced osteoporosis and the bone loss, and occasionally for flares, it's absolutely these are medications that have potential side effects, and giving them over long periods of time can have increased risks of different types of fractures, different types of bone issues. And so making sure that you're aware of those risks and benefits is really important as you go into this. And in addition, I think for some clinical trials, the use of bisphosphonates is not allowed because it makes it difficult for them to do the assessments. So make sure that before you get any of these types of medications, you discuss it both with your clinical trials doctor if you're involved in trials, as well as your doctor at home, about the risks and benefits.
So imatinib is a kinase inhibitor. It has no effect on ACVR1, but it has effects on other things that are off, what we call off-target effects for what was originally designed for, but they're very much on target for FOP. They're not the center of the bullseye, but they're on the periphery of the target. So Several years ago, Bob and I and our colleagues at Penn, Hai Tao, he was in the audience, I think, today, was the lead author on that paper. Hai Tao studied, and we studied the effects of hypoxia. We know that when inflammation occurs, the hypoxia pathway is stimulated, and that amplifies, dramatically amplifies, like a loudspeaker. Like if I didn't talk, you can't hear me. Now you can hear me. The hypoxia gene is like a speaker. It's an amplifier, and it dramatically amplifies the signal, the water that comes down to stimulate the bone. And we knew that imatinib was a blocker of, among the many properties of imatinib, was a blocker of that signal. And we tried it in the animal models, and it dramatically decreased the hypoxia in the cells. It also decreased by about 70% the amount of bone formation. It turns out that hypoxia, the off-target effects of imatinib are, it blocks the mast cells. It blocks, maybe not completely, but it hits the mast cells, it hits the FAP cells, it hits the multiple inflammatory pathways, and it hits what did I say, mast cells, hypoxia pathway, the mast cells, and the FAP cells as well. So just to put this in perspective, there was a 2-year-old child who had rampant flare-ups of FOP. And by the time the child was actually 2 years old, the flare-ups had affected the neck mobility, the shoulder mobility, and the elbow mobility. And these flare-ups were going on and on and on, and they were unresponsive to prednisone. And the parents were desperate. And we said, we don't know what else to consider. We had tried everything in our armamentarium to symptomatically quell the flare-ups. We talked to the parents about the off-label use of this approved medication that was approved for other medicines. We talked to them about the side effects, and that we put the child on it, and within several weeks, the flare-ups decreased. Now, I have no idea whether that stopped the bone formation or it did not. But the child was much more comfortable. And it could have merely been coincidental. It could have merely been coincidental. And there have been several other desperate situations like that with children, just to quell the misery of very young children of these ongoing back flare-ups that cause tremendous inflammatory changes. We've asked the pediatric oncologists and hematologists to consider that. They carefully monitor it. And now I think there's 10 children that have been on and off imatinib at various times. And in 9 out of 10 children, the flare-ups have decreased within several weeks of being on the imatinib. Again, I have no idea whether it makes the bone formation better or worse or stays the same. But it's not used for that. It's simply used to quell the misery of these flare-ups. And it's not a generally used medication. We do not recommend it. It is really, really only used symptomatically. Now, we could do a clinical trial with it, but with imatinib. But the question is, how are we going to do a clinical trial, and how are we going to fund it? And since the medication is available, are individuals willing to consider using the medication? I don't think in any shape or form that this medication is an ultimate answer to FOP. It's simply used as an adjunct to the symptomatic treatment in very, very controlled and rare situations.
Okay, thank you. We've got time for 2 more questions, one over here and then one over here.
Okay. Hi, my name is Gabby Assenlee. This is my first gathering. Hi. Okay, everyone turn. So we're from Miami, so we just drove up. I have 2 questions. So the first one is, why am I cold, like so cold all the time? Is it because I have more bone? Like, I know I have a lot of blubber, thanks for the prednisone, but just the winter chill goes right through me. So that's the first question. Do I go both? Okay, so the second question is, I noticed with what Mona was saying is that around my period time of the month, I have inflammation, and it's like my body is telling me that, oh, I'm getting my period. But I always think, I'm like, is it a flare-up? Like, what's going on? And then I bleed. So I don't know if it's the hormones that it's telling me, like, you know, I have inflammation around my hips and pain. Then, yeah, so those are the two questions.
So I guess I'll start with answering, and then you guys can weigh in. In terms of why you feel cold all the time, I think it's important to make sure that there aren't any other reasons that you could be feeling cold all the time, and not just say, oh, this is related to FOP. So obviously, as an adult endocrinologist, the first thing we think about is that your thyroid. Could there be some thyroid abnormality that could be contributing to why you're feeling cold all the time? Sometimes, you know, I know that Ed has done some research, and you had a presentation about some of the thermal changes in the neuropathic pathways. And so we don't know how FOP gene could be contributing to that, or if there's any problem with the circulation that could be contributing to why you're feeling cold all the time. And then regarding your second question or comment, it's a very interesting question that I really don't know if we have the answer for that. We do know that there's a lot of hormonal changes that can also happen within a cycle. And I think that would be kind of an interesting thing to look at. Just going back to maybe following up with you is, do you feel that you have inflammation in your body? Has that ever led to a flare-up, or do you feel any bone forming? Or if you've, you know, anything that you've noticed in terms of cycles. These are all very important questions that we do need to look into and to better understand.
And I would add, so there are a couple of things. One is it would be great, hopefully you have an Ask a Doctor session, because I think we can discuss this in a little bit more detail. But I would emphasize that patients with FOP have FOP, but they also have what everybody else gets. And so thyroid disease is very common. It's about 1 in 100. You know, different types of conditions occur just as commonly in the FOP population as you would see in the regular population. So it is actually really important to remember that not everything that a patient experiences is going to be FOP related. Some of it might be. That's certainly something to consider. But when we think about medical management, those are other aspects that we would want to, you know, you don't want to think of the zebra first. You know, when you hear hoofbeats, you should think of the horse, and just make sure that you're looking for those types of common things that all of us will be exposed to.
Great, thank you. And then the last question goes to Winston, also a first-time attendee.
Is there any relation between FOP flare-ups and the common cold or flu, or just being sick in general?
Yeah, so that's actually a great question. We don't have very specific pieces of information yet in terms of, you know, what the correlation is, but there are some pretty clear indications. So certain types of infections do tend to be associated with FOP flares, just on a reported basis from information that you have given to the clinicians, and those are primarily viral infections. In addition, we know that patients who receive the flu mist, the intranasal form, so we do not recommend that because that's a live attenuated virus for the flu vaccine. There seems to be an increased incidence. There's no formal data on this, but it seems to be an increased incidence of flares associated with that. So because of that, we do suggest being very careful of trying to avoid viral infections.
Yeah. Many, many years ago, back in the 90s, we did a survey of the FOP community at the time, and showed that there was a clear correlation, not cause and effect, but a correlation with influenza or influenza-like illnesses and flare-ups of FOP, a temporal association. Whether that's due to the virus within the muscle or the connective tissue, as some have shown, whether it's due to the cytokines or the inflammatory proteins that circulate through the body that can stimulate potentially a flare-up that Ed has shown, or whether it's due to the coughing and the muscle trauma that occurs often with these respiratory illnesses. We don't know, but certainly there is. And then flu is a killer for if you're healthy, and then if your lung capacity is decreased, it's a tremendous risk factor. So that's why we recommend the flu vaccine.
Yeah. And actually, that's a great point that Dr. Kaplan is bringing up, because if you get the flu, regardless of whether you've had a vaccine or not, or you have an upper respiratory infection, it's best, we do recommend that you reach out to your primary care physician as soon as possible to get the flu test, because if you are tested positive for flu, there are some medications that are antivirals. One is the brand name is called Tamiflu, that we do recommend to try to decrease the severity of the flu and to try to decrease the coughing, to decrease the inflammation that is associated with that. We don't have any data on whether or not this improves flare rates or improves long-term outcomes, but just from a physiologic standpoint, this is something that we try to recommend.
The other thing is always to review kind of the CDC website, and they do comment about, like Ed mentioned, if you're having an active flare-up, we don't recommend that you get the flu shot. But your caregivers and your family members, it's important that they do get the flu shot as well, so that even though you're not getting the flu shot, you're not getting it from your family members or anyone around in the household, and try to avoid areas or being in a busy, crowded area where you could be exposed to the flu. So those are other measures that you can do to prevent you from getting the flu or respiratory illnesses.
Okay, well, thank you so much. I know that there will be lots of follow-up questions at breaks or maybe in the Ask a Doctor and Ask a Dentist meetings, but we just appreciate your commitment to the community, and you have a long week here. These folks have been here since Sunday in meetings for the International Clinical Council and then the FOP Drug Development Forum, and they're staying through Sunday and Monday. So we are just blessed to have their commitment and their willingness to sacrifice and be here with us for this long week, sacrifice of their personal time. I know that they love being here with you. So please help me in thanking them.